Hi, everybody. Welcome to another edition of Ask the Expert with IDSOG. My name is Anna Powell, and I'm a generalist at Johns Hopkins School of Medicine with extra training in reproductive infectious disease. And today I am speaking with my friend and mentor, Dr. Paul Nyirjesy. So I'll let him introduce himself, and then we'll get started.
Thanks, Anna. So I'm a professor of OBGYN at Sidney Kimmel Medical College at Thomas Jefferson University in Philadelphia, and I'm the co-director of the Jefferson Vulvovaginal Health Center.
Great.
Thanks for having me. This is really fun.
Yeah. Well, it's going to be a good talk. So our plan today is that we're going to be discussing the upcoming 2020 CDC sexually transmitted infection guideline updates for vulvovaginal candidiasis. So Dr. Nyirjesy, can you tell us what is new in diagnostics? And I think we are going to start with a little discussion about uncomplicated versus complicated candidiasis.
Sure. So, in some ways, what was true 30 years ago is still true nowadays. And so the main thing is that office microscopy is still considered the best test to do first line. And the gold standard for diagnosing a yeast infection is still going to be doing a yeast culture. And both of those tests, both a KOH and a culture, are underutilized, but there's still the right things to do in patients. The KOH, I think, should be done in uncomplicated and complicated candidiasis, and the culture, whenever there's a doubt about the diagnosis, culture should be done. And if you do cultures, I think the thing to emphasize is you want to make sure that you specify that it needs to be a yeast culture, not just a routine culture where they check for bacteria and other things. And then you also want them to speciate the organism, because if it's positive, it's really helpful to know which yeast is positive for.
Yeah, and I know we were going to talk a little bit more about culture later, but now that you mention it, is there any utility in asking for other susceptibilities besides fluconazole, because the MICs are often not standardized or not reportable in a helpful way?
Yeah, so we don't routinely do susceptibility testing, and even in our complicated patients, in general, if it's a Candida albicans infection, it's going to be susceptible to fluconazole, and in general, if it's something other than Candida albicans, fluconazole may not work, although fluconazole sometimes does work. So where susceptibility tests can come in handy is in somebody who has a positive culture despite being on treatment, or who takes a treatment and finds that there's no impact on her symptoms if she takes the treatment. So the tricky part is that susceptibility tests have never been all that reliable and all that helpful. You have tons of organism in the vagina. If you're using an antifungal cream, you can get grams of cream in there. And so that interaction between bug and drug has always been a little bit unpredictable in terms of susceptibility testing. And then recently, two IDSOG members, Claire Danby up at Maine, working in Jack Sobel's lab, published a study that showed that if you do susceptibility testing, it's very different if you do susceptibility testing at a pH of 4 or 4.5, which is the normal pH of the vagina, as opposed to a pH of 7 or 7.4, which is what most labs will run for you. And so what they found is that at a lower pH, some of the drugs that look as though they'd be really good, particularly for Candida glabrata, turn out to be not that good. And with the exception of the cytosine, all the other drugs they looked at, there was a big increase in resistance profiles with susceptibility testing. And so with the susceptibility testing, right now, most labs aren't going to be Jack Sobel's lab. They're not going to be able to do susceptibility testing at a low pH. The guidelines are going to recommend that be done, with the hope that the labs will maybe start considering it. So when I do susceptibility testing, I tell patients that I use it to give me a general idea of what drugs might work, but because it's not like susceptibility testing with the UTI, I don't routinely do them.
Okay, that's good to know. So just give us a quick refresher about what is uncomplicated and what is complicated candidiasis.
So uncomplicated infections would be patients who come in, they get 1 or 2 infections a year. Their symptoms aren't really bad. They're normal, healthy women. And you can give those women anything and they'll get better. In fact, in placebo-controlled studies, probably 30% will feel better with no treatment whatsoever. But then the complicated patients are patients with really severe symptoms. So if somebody looks really red or she tells you she's really itchy, that's somebody with a severe infection, or somebody with recurrent disease. And the definition, by the way, Anna, of recurrent is going to be changing. It used to be 4 infections a year. Now it's going to be 3 infections a year. And then also if somebody has other reasons to not handle infections properly. So somebody who's immunocompromised, like a cancer patient or someone taking chemotherapy. And also I kind of lump into that patients with different skin conditions like lichen sclerosis, which I think makes them more prone to not responding to standard treatments in the same way.
Okay. And why is the definition for recurrent disease changing?
I think that most people feel that 1 or 2 infections is not a big deal. Once you get to 3 or more, it becomes more problematic for patients.
Okay.
The decision to go from 4 infections a year to 3 infections a year, quite honestly, is somewhat arbitrary.
Oh, okay.
But the most recent study, but why was it 4 in the first place?
Yeah.
Because when Jack Sobel did the first studies on recurrent yeast infections, he thought that 4 infections sounded right because that was what was done for recurrent UTIs.
Oh,
And so it's a somewhat arbitrary definition, but I think that most people now are going with 3. My understanding is that in the CDC guidelines, it's going to be 3, not 4 anymore.
3 or more. Okay, that sounds good. So one thing that clinically I think we're doing a lot more of now, and I think the guidelines are starting to address, is PCR-based testing. So can you tell us a little bit more about what's been going on with PCR testing?
Sure. So, so the big difference between the last set of guidelines and the previous set of guidelines is that now there are PCR tests that are FDA cleared. So they've undergone clinical trials. They're considered appropriate to use. The way that I think of them is that they're pretty good. I think for Candida albicans, the sensitivity and specificity are very good. But then for the non-albicans yeast, I think that they may not necessarily have quite as many organisms or quite as many patients who had those organisms to really say, oh yeah, this is going to be a great test for some of the non-albicans yeast. And then depending on the manufacturer, it's kind of a different profile of non-albicans yeast that they're testing for. So I think the big advantage of PCR is that you get a quicker answer than with culture. Culture, it can take you 4 or 5 days to get a positive, and then if they're going to speciate it, it might take a little bit more time. Although if it's Candida albicans, a lot of times they get the speciation done pretty quickly. So I think that PCR has a role to play, but I still think that culture is a better test. But for those who can't get a culture done, just keep in mind that first of all, you want to know which test your lab is using. Are they using one of the tests that's been FDA cleared? If they're not using one of the tests that's FDA cleared, have they done studies that show the performance characteristics of their test? And then you'll really know whether it's a reliable test or not. And most labs should be willing to tell you what their performance is like. By the way, Anna, in terms of diagnostics, so one test that's actually going to be out is the Affirm test. So, the Affirm test, it was always considered a test you could do at many institutions and many labs. They offer what's called the vaginitis panel, which is the Affirm test. So the problem is, and we're not here to talk about BV or trichomonas, otherwise we'll be here all night. But the problem, first of all, is that with BV, it actually overdiagnoses BV 40% of the time. And then when it comes to yeast, the sensitivity is only about 60%, which is not much better than microscopy, because microscopy is about 50%. So, so the Affirm test is actually no longer going to be recommended in the upcoming guidelines.
Oh, okay.
Yeah. Although, by the way, I should probably say, so the guidelines haven't been published yet. There's been a public commentary period. This is what I anticipate will be in the guidelines, but there's a chance that when they come out that it's going to be different than what we talk about tonight.
That's true. Thanks for clarifying.
Need that disclaimer in there.
What's that? Yes,
I need that disclaimer.
That's right. So I guess in my practice, where I'm finding that I'm using PCR more and more in addition to microscopy, because as we know, it's 50% sensitive, but I also find that not all insurances will cover it. So it seems to be, it's a little bit more expensive, obviously, than microscopy and like culture testing. And then my understanding is that labs need special equipment to run it. So not all labs may even be able to help you with that.
Mm-hmm. But I think what's making PCR more popular is that out in the general community, most OB/GYNs aren't doing microscopy anymore. And for some reason, they never think to do culture. And so there's this huge diagnostic void, and PCR at least helps to fill that void.
Yeah, that's a good point. Okay, great. So we had talked about the definition. Oh, I guess tell us again. So recurrent vulvovaginal candidiasis refers to 3 or more in a year. And there's also some exciting new advances in treatments. But before we get to the new medications, you had mentioned that there's actually quite a bit that is not changed from the prior guidelines. So can you tell us a little bit more about that?
Sure. So, so for uncomplicated candidiasis, there's this lengthy table of all the different treatments that are available to treat yeast. They all really have been studied as treatments for Candida albicans infections. They all have been, they all have pretty similar results. They're probably all fairly interchangeable. And so the only thing that was done with the recommended treatments is, I think, we looked at whether any of the treatments were no longer being manufactured, because sometimes it's kind of a moving target. And I don't think there are actually any changes, if I recall correctly. So I think that table is going to remain the same. And so that's really going to be staying the same. And then for recurrent disease, there are going to be very few changes either right now. So fluconazole is still considered the gold standard, especially if it's a Candida albicans infection. The one thing that's being emphasized a little bit more is that so what we usually do is we give patients 6 months of fluconazole. The original study was 150 milligram pills. You give the patients 3 doses, 3 days apart. Then they go to once a week fluconazole for 6 months. I've always done things a little bit differently. I think sometimes maybe I march to my own tune. What can I say? But I've been using 200 milligram pills for 30 years. It goes through prescription plans a lot easier than 150 milligram pills. And then I have patients take 200 twice a week. But the overarching concept is you want to treat them for 6 months, and once a week fluconazole is the standard. So the things that are going to be brought up a little bit more in the upcoming guidelines is, first of all, that recurrent candidiasis is not a trivial disease. There was a very nice review in the Lancet that estimates that in the United States, there are billions of dollars, and I want to say 10 billion, which might be an exaggerating, but an exaggeration. I'm actually not sure it was an exaggeration. There's really a huge amount of healthcare dollars and kind of dollars spent with or wasted with lost productivity because of recurrent yeast infection. So there's really a very important economic burden. And we also now know from several different studies that after 6 months of fluconazole, recurrences actually can be fairly common. And so the focus should be less at saying to patients, oh, take 6 months of fluconazole, you're done with this forever. It's more focused on, we're going to get this under control. You can go about your business taking a medication that in general is very well tolerated. But there's a chance that things are going to come back later on. And if they come back later on, we'll have no hesitation to put you back on a long course of medication. That way you can lead your life and be comfortable.
Right. Okay.
Yeah, so for Candida albicans infection. So the other thing is that there are some concerns now about pregnancy, which makes management of somebody with recurrent yeast in particular is trying to get pregnant a little bit more complicated. There have been some studies associating fluconazole with possible increased risk of spontaneous abortion. There's a question mark about possible congenital malformations. And so especially when somebody's trying to get pregnant or early in pregnancy, I think people need to be aware of those associations. I tend to not use fluconazole at all in pregnancy at any stage, but I just think I'm conservative. Other people may feel more comfortable using it later on in pregnancy, but early on, I really avoid it.
But that's not a new, I feel like that's not new information. Maybe it's just more emphasized in the guidelines now, right?
No, so some of the new information are actually since the last set of guidelines. So there was a study out of Canada about Candida, a little yeast humor, which raised some concerns about malformations. And then also there was a Danish study, which I think was in 2016. So those were two of the studies. So those were you know, the guidelines have always been conservative about fluconazole use in pregnancy,
right.
but now there's a little more substance to why those concerns exist. So
got it. Yeah, so that poses some interesting diagnostic, or I guess treatment challenges for recurrent yeast for women that aren't on contraception, who are or are not planning pregnancy.
Right. Yeah, and so yeah, and you know, but there are alternatives, right? So clotrimazole, the 7-day product, if patients use an applicator twice a week, there's anecdotal evidence that that's helpful. Probably true of miconazole 7 as well. So the concept is still the same, that for Candida albicans infection that's recurrent, put them on something over a long period of time to get it under control.
Okay, got it. So let's talk about now some of the new medications that are coming out that have challenging to say names. So the first one is ibrexafungerp, which is that has a new drug class, is my understanding. And tell us a little bit more about some of the studies that are showing some promising data.
Yeah, so there are 2 new drugs in clinical trials. So ibrexafungerp is a drug that has a different mechanism of action. It attacks the cell wall as opposed to the cell membrane, and it's a fungicidal drug. And so some of the results actually were presented at IDSOG, I forget if it was last year or 2 years ago. But the data with this drug is that it seems, in terms of efficacy, comparable to fluconazole at a minimum, but the numbers are a little bit too small to really tell whether it's going to be superior to it, but it's a different mechanism of action. The one thing we hadn't talked about with Candida albicans infection is that there are more and more Candida albicans infections that seem to be resistant to fluconazole, and so it's kind of high time that we had a medication with a different mechanism of action, and hopefully it'll turn out to be an effective option, but it's still in clinical trials. It will probably be approved this year unless something happens, or at least that's what I would think based on you know, how things are going and what you see on clinicaltrials.gov. And it'll be a new option, and exactly where it fits in, we're not sure. And similarly, there's another drug, I know it better by its number, VT1161. And when there were data presented at IDSOG meetings, it was again called VT1161, but the name is oteseconazole, tough name. But this is a drug that has a really, really long half-life. It has a similar mechanism of action to fluconazole, but it's much more specific for the target site, seems to have fewer drug interactions. And in the one study that was published in the Gray Journal, after stopping treatment, only 1 patient recurred in the 6 months after stopping treatment, as opposed to, you know, I think there were 100 patients who were in that study. So one would have expected about 50 to recur. So it looks very promising. And then it looked, with both drugs, they look very broad spectrum in terms of MICs, although we already talked about the limitations of susceptibility testing.
Yeah, and I was trying to pull up some more information about outside of vulvovaginal candidiasis treatment. So it seems like it's nice that there's this new oral option as opposed to, you know, intravenous, because of I think the levels that get into the vaginal tissue.
Yeah, so with intravenous, there's still been no evidence that any sort of intravenous drug works to treat VVC, except for, I guess, fluconazole probably would because it penetrates into the vagina. This is probably true for you too, Anna. When patients sometimes end up with an infectious disease doctor before they see somebody who really has a lot of experience with complicated candidiasis, and sometimes they'll get these really prolonged courses of IV antifungal therapy. They'll get ports put in, they'll get all these different things done to them. And they get drugs that end up not really penetrating to the vagina and not really having any efficacy at all. So it's kind of a double whammy and an expensive treatment approach that has little value. So
Yes.
but these two drugs both get into the vagina.
Okay, that's good. It sounds like they work pretty well. And then I think you had mentioned, but for the ibrexafungerp, there was actually some data comparing it to fluconazole.
Right. Their initial study was a dose ranging study. And so it wasn't really powered to compare it to fluconazole, but fluconazole was one of the comparator groups.
Oh.
And actually, I think their very first study, which was don't you hate technology, as we are here on our Zoom meeting. They in their very first study, they actually seemed to suggest, based on the results, that 60 days out, patients might do a little bit better with ibrexafungerp as opposed to fluconazole.
Yeah, that's what I had picked up on, and it sounded promising. But I guess we'll see.
So the data are suggestive, but it's not definite yet. So. Or not definite, I shouldn't say the word yet, because who knows what will happen.
Right, exactly. So then there may also be, it sounds like there's also a vaccine candidate that is.
Yes, so we were involved with the vaccine study, and it was really an exciting concept. And the concept was that this vaccine was meant to help women produce antibodies to a specific protein that Canada uses to bind to the tissues. And the thinking was, if you could bind tissue blocking, you could prevent disease. And it was a really big study in terms of the effort put into it. But when the data, the codes were broken, overall, there wasn't a big difference between people who got the vaccine and people who got placebo. Interestingly, the one benefit was that patients who were under 40 who had gotten the vaccine seemed to have less severe symptoms than women who'd gotten the placebo. So some of the women had less symptoms from yeast infections if they got the vaccine. And I actually had one patient who was actually quite dramatic. She could go from no infection to a really severe infection almost overnight and come in terribly swollen and in terrible pain. And I enrolled her in this study, and when she got the yeast infections, it would take her 6-7 days to call before she'd come in or want to come in, because it hadn't been that bad. And she found there was really a very dramatic difference. And I didn't know what she'd gotten, but when we broke the code, I was not surprised to find out she'd gotten the vaccine. But I'm not aware of further studies going on right now with the vaccine. So I'm not sure if it'll be developed further or what's going to be happening on that front.
Okay. And I know we've talked a little bit about my interest in boric acid, but I was kind of excited to see this information about the TOL 463. And so it seems like it's boric acid enhanced with some EDTA that gives it a little bit better activity. But what's been going on with TOL 463?
So they had published one study looking at both treatment for BV and treatment for yeast, and the drug looked promising. And it's kind of a very encouraging first step. Boric acid, by the way, as you know, it's been around since the 1860s. The one thing, by the way, that's going to be new in the CDC guidelines is that they're going to recommend a 3-week course of treatment for non-albicans yeast infections instead of a 2-week course of treatment. Quite honestly, when I use it, I usually use a minimum of a 4-week course of treatment, but the guidelines are going to say a 3-week course of treatment. But then the addition of EDTA seems to be helpful. So we'll see what happens with that. And the concept is that the combination may be very effective at removing biofilms. Biofilms are definitely a factor for BV. one study actually by the group that did the work showing that BV causes biofilms showed that yeast does not cause biofilms. On the other hand, boric acid definitely has antifungal qualities to it, and hopefully the addition of EDTA will make it even more effective.
Yeah, it'll be exciting to hear more about that in the future.
Yep. So
good. So we've now, so the couple last things left before our time is up, but we were going to also just mention about the special population section. So we kind of updated about fluconazole and pregnancy and how there's more data suggesting that, teratogenicity, so we don't want to be using that. But there's also, of course, the women living with HIV recommendations seem more or less unchanged, unless, I guess, all the medications that we have available are still, available to be used for those patients. And women with HIV that are poorly controlled or who have lower CD4 counts may be at higher risk for developing vulvovaginal candidiasis, right? But otherwise, it sounds like not too much new data there.
Yeah, I mean, so when I did a literature review, there was very little to add. So yeah, so.
Okay.
So.
And then as far as, and I'm not sure if this is going to be elaborated much in the guidelines, but we had also mentioned like things coming down the pipeline or what future studies should be thinking about, or like what's next in terms of future developments besides the stuff we've mentioned already.
Well, so one thing where there's definitely a need for further study is probiotics, right? So they're the most commonly recommended thing for women with recurrent yeast infections. There's never been any clear data to show that probiotics are helpful. I think the next set of guidelines are going to kind of go out of their way to tell people to stop recommending probiotics, and and probiotics, it's not clear how helpful they are for yeast infections anyway, because most women with a yeast infection have normal types of lactobacilli. But I think that now there was a study with a probiotic that looked promising for bacterial vaginosis. Might be interesting to see if that does something for yeast infections. And
right, I was going to say, do you think that might decrease the risk of post-treatment BVC in the setting of treating the BV?
So with the products that are available commercially, the answer is a definite no. And one of the best probiotic studies is about 10 years old. It was done out of Australia, where they randomized patients to a probiotic or no probiotic after taking any antibiotic. And it was I think they did it in a province in Australia, and they very clearly showed that it was a futile effort and it wasn't worth doing. So
jury's still out, but sounds like it's a no-go for now.
Yeah, and consider me a skeptic.
Okay, fair enough. And then are there, I guess we had touched a little bit on are there any new treatments that you know of coming down the pipeline specifically for non-albicans candida?
No, I mean, I think with both the oteseconazole and brexafungerp, based on their MICs, there's reason to believe they may be effective treatments for non-albicans yeast. The question is going to be, what's the dose? What's the duration? How effective are they? Is one drug better than the other drug? And the problem is that non-albicans yeast are so uncommon as causes of yeast infections, unless you're at a specialty program, that it's going to be hard to get, like both of us, it's going to be hard to get enough patients to do a really well done placebo-controlled study. So it's probably going to be case series where people get the tough cases and then they get a sense of how effective those drugs are.
Mm-hmm.
So, and keep in mind that after boric acid, the next option is flucytosine cream, which has to get compounded and which is well over $1,000, and where resistance develops very quickly. So it's kind of a one shot. It either works or it doesn't work. And after that, you end up kind of scrambling, trying things, by trial and error, which is not a very satisfying way to do patient care.
Well, then there's like nystatin and amphotericin B, which I know from our experience together are not used very often and seem to be much less effective.
Mm-hmm. But then they kind of work in some patients, so sometimes you have to try it, and yeah, it gets very messy. Once you get beyond boric acid for non-albicans yeast infections, it's not an easy scenario.
Great. Well, thanks so much for speaking with me about all these exciting updates. And stay tuned for the next Ask the Expert. Sorry.
All right. Thanks, Anna. Take care.
Have
Bye-bye.
a good night.